Hello, everybody. I think Paul and Mia, we are really impressed seeing this crowd of people. So it's really a privilege to be here and to discuss with you Waldenstrom's disease this morning and the whole day. So just to start and to introduce myself, my name is Prof Buske. I'm physician, hematologist, oncologist in southern Germany at the University Hospital of Ulm, involved in clinical management and clinical research in indolent lymphomas, in particular in Waldenstrom. And with many, many colleagues in Europe, we founded 9 years ago the European Consortium of Waldenstrom's Macroglobulinemia, trying to move, let's say, clinical management in Waldenstrom forward, of course, also together with our US colleagues. So this is my, let's say, my background a little bit, and I'm very happy to do this session together with Paul, who will introduce himself now with a few words. Paul.
Well, hello again. It is a privilege to be here. I am Canadian, although I'm the chair of the IWMF. It's very much an international organization, and we love to partner. We love to partner with Christian and his European Consortium of Doctors. We love to partner with the WMUK. We hope that we will be supporting each one of our partners with the resources that the international organization has. And I think when partners work together, we can solve so many of the WM problems that we all live with. And we're so grateful to people like Christian for his dedication, for all the people who work at WMUK, for all the people that make such a contribution at the IWMF. So it's wonderful to be able to relate with you today, speak to you, and hopefully we'll get to talk to all of you. So Christian, we're gonna solve WM right now.
So perhaps I just want to mention, it's really unique what you are doing here. So I'm not only involved in Waldenstrom, but I'm doing a lot of other lymphomas, marginal zone, mantle cell lymphoma, follicular lymphoma, also diffuse large B-cell lymphoma. And to have such a tight, connected patient advocacy group working with us physicians together, it's really unique. So before I forget to say this, it's really amazing. And so what Paul and I, we said we will try to do it very informal. So we are not standing up, not because we are too lazy, but we want to stay seated. We have this wonderful technical equipment, and we want just to chat with you and with us a little bit. So it should be not an upfront presentation. So you can always interrupt us, or we ask you questions. So please see it as a very informal exercise. Okay, so
if they interrupt us, they're probably awake. But if they don't interrupt us, they're probably
And when
asleep.
we see that you start sleeping, we will ask questions. Okay, so we have, the topic is, I think it was a beautiful introduction into Waldenstrom we just heard. The topic is, what is ongoing? So what are our standard treatments? So where might the development go to in Waldenstrom? So this is a little bit the topic, just perhaps deepening a little bit what you heard before. So current Waldenstrom treatment landscape, of course, I have a lot of disclosures, but I always say I have so many disclosures that I'm completely non-biased. So, and this is probably not the full list. So as you know, so the journey started actually 1944 with Jan Waldenstrom, who really for the first time recognized that he had patients with specific symptoms. And his achievement was to understand that these group of patients belong together. So this is why he coined the wording Waldenstrom's macroglobulinemia, because he was actually really the first. And you see, it's more like an anniversary. We have 24, and it was published 44. And so this very old historical publication you can still see. So you can go to the internet, it's scanned in. Of course, it's in medical language, but it's very amazing to read these old manuscripts. So actually, we will hear about Bing Neal later, which is a rare, let's say, incidence where Waldenstrom affects the central nervous system. So this was published even 8 years ago, 1936. And also this paper, published by the two doctors, Bing and Neal, you can still read. It's very amazing. So here the journey started, and Paul, whenever you want to say something, you interrupt me. So and you know what is really amazing is the dynamics we see in our growing knowledge about Waldenstrom. And I think it's very remarkable when you look at this slide, and what are 20 years? We all know a decade passes like this, so these are 2 decades, it's nothing. But when you look back what we had 20 years ago, it was amazingly little. Yeah, and this is just illustrated here. So we had no models of Waldenstrom's macroglobulinemia. The biology of the disease was rarely understood. Yeah, there was no research specifically for Waldenstrom. So there was research on larger lymphoma, more frequent lymphoma entities, but not on Waldenstrom. And yeah, that's true. There was not any specific development for Waldenstrom. So the only thing what people did, what we physicians did, we looked what worked in more frequent lymphomas, and we just took it. Just copy-paste. Yeah, so there was no own Waldenstrom thinking, let's say. And Paul, you have your own experiences when you look back a little bit. Yeah.
My mother, when she had it, there were just no treatments. She had blood transfusions that lasted shorter and shorter periods of time. She died in the 80s, looked like an AIDS patient that was so prevalent and we knew nothing more about it. We knew she had WM, but they could do nothing, and it was terrible. And I just think how fortunate all of us in this room are that we all have treatments that weren't available such a short time ago, 1 generation ago. It's amazing.
Yeah, and you also mentioned to me so that there was also no patient group existing, so that you could not exchange experiences with anybody at that time.
Yeah, I mentioned earlier that she never met another WMer, and the advantages we have of just sharing stories. I've walked around today, and it changes our understanding, and it's spiritually so helpful to all of us.
Yeah, perhaps, Paul, you also add a little bit, because I think the IWMF was really one key driver in pushing forward WM-specific research. Perhaps you lose some words about this.
Yeah. The IWM did its first research in 2000. We had that big meeting in 2005 to try and convene where we were going. In 2015, we set out a roadmap of research, and we got the leading clinicians and researchers together and found out where the holes were in our scientific understanding of the makeup of Waldenstrom's, and they came together. And in 2024, Christian came to us. We had another meeting to redefine the roadmap because we had made so much progress. We had uncovered so many things, the mutations that take place, and we've now got another pathway, another set of roadmaps with a different criteria to help researchers find out what the next things are that we're going to uncover with WM, and we're going to solve this together by doing that.
Yeah, and it's really It was so successful, and again, it's unique. I don't know anything like this in other lymphoma entities. And it's just an example. So this was one of the pivotal or milestone publications we had in Waldenstrom, understanding the biology of the disease. Not only the biology, you all know that these mutational events in MYD88 or MYD88 have also clinical implications. And this was a project which was also funded by the IWMF. So it was really a key driver for major contributions in the field of Waldenstrom, and also the discovery of the CXCR4 mutation, which is the second most highly recurrent mutation in Waldenstrom, was fostered and funded by the IWMF. So I'm not telling this because Paul is sitting beside me. It's really, we have really to praise and to applaud IWMF for this commitment, because also we are really depending on research money, on funding. Otherwise, we cannot do this, because normally our hospitals are not paying anything for this kind of research. Yeah, so you see that this journey goes on. Yeah, it's not the end. We will have no time to chat about this, but you know, there are larger efforts to go beyond MYD88 and CXCR4, because we know there are many other recurrent genetic alterations in Waldenstrom. And just as an example of many other colleagues, Zach Hunter is one of the, let's say, stars in this field, trying to dissect the molecular biology of Waldenstrom, to understand which genes or which genetic alterations are drivers for disease development. And when you know what is driving the disease, you can think about targeting these drivers. So the biology is always like a platform, like the basic, also to develop new ideas. Yeah, so, but going back a little bit, you know, so where we are coming from, decades of frustration, chemotherapy, so this is a little bit hard, but there was a time, you know, where we tried to move forward, not so much in Waldenstrom, but in other lymphomas, to move forward by modifying chemo, because we didn't have anything else. We had just chemo. We had no ibrutinib, we had no zanubrutinib, we had no venetoclax, we had even not rituximab. So we tried to modify, but it didn't work. So we really, you know, were depending on completely new developments. Nevertheless, you will see when we go through the current treatments option that chemotherapy is still very important, but without, let's say, the discovery of new drugs, targeted drugs, chemo-free drugs, we would have really difficulties to move forward. So where are we now with current treatment? So we are sitting here in the year 24. So what do we have? We have more. Yeah. So you see these pillars of lymphoma treatment, and this goes beyond Waldenstrom. It's also true for many other lymphomas. We have now different tools. We have, for Waldenstrom specifically, rituximab available as an anti-CD20 antibody. It's a monoclonal antibody, so it has nothing to do with chemo. We have now the small molecules, as called here, so is ibrutinib, zanubrutinib. We have also acalabrutinib, but we are sitting in Europe, not in the US. So for us, acalabrutinib is not available, but ibrutinib, zanubrutinib. And we look a little bit here into the future with the last pillar, which are, let's say, immune treatment and bispecifics. I will show this later on. It's a very exciting development. And actually, we have to congratulate Josephine, who is sitting there. So she is performing the first bispecific Waldenstrom study in Europe. I think it's a very exciting new development. So I think what is clear is this was always our dream, to go away from chemotherapy. Why? Because probably you also, we think it's in some way a little bit like a bulldozer treatment. But again, important, still important. But let's say the trend is clearly to go away from chemotherapy. And then, the next trend, let's say, is to go away from intravenous application, so IV application, because it's easier to take oral
It's also
treatment.
cheaper. I had IV treatments in the hospital for once a month for 6 or 7 years, and then I switched to subcutaneous, and now I do it at home. In fact, last night I did it after dinner and before, and it's so convenient. Whereas before you're tied to a hospital appointment, and last night I was just tied to my bed for 45 minutes, so it was a lot better.
Yeah, I think it's a great development. So there are some, hurdles for this, which have nothing to do with you or with us, but there are in some countries, financial reimbursement policies which, let's say, push the doctors towards IV application because they get better reimbursement. So totally crazy. Yeah, but I think we all agree that this is actually the way to go, to move away from IV, as Paul said. So this was the dream, and is the dream to have the magic pill. I remember when I was invited by a company which invented ibrutinib to their first ad board in the US, they told me the problem is solved. Yeah, so this was a little bit bold. Yeah, and but I remember very well. So we still do not have a magic pill, but we are approaching more and more this conceptually this magic pill for cancer. So what about treatment? Again, we are sitting here 24. So what do we have? So this is, let's say, it's the German, Austrian, Swiss official guideline, but I took this because unfortunately the European ESMO guideline is completely historical now. It has to be updated urgently. But I think it summarizes very well how we see there might be some small deviations. So we have to ask Josephine and Shirley, perhaps. Perhaps it is a little bit different in different countries. And it's for sure a little bit different than in the US, because we don't have all the drugs available compared to the US. So what do we do? So when you have Waldenstrom, we only treat newly diagnosed, let's say, we only treat when you need treatment. So how is this defined? First, by your quality of life. Very simple. You as a patient are the major factor to trigger us physicians to start treatment or not to treatment. So there are some situations where we would recommend for you treatment despite the fact that you're feeling well, when you have skyrocketing IgM, or profound anemia, which you tolerate very well nevertheless. So there are certain, let's say, situations, but normally it's you who decides based on your quality of life. So when you are symptomatic, then what we still do is our chemotherapy. So rituximab plus chemotherapy. We will come back to this later. And as an alternative, you have the BTK inhibitors, which is ibrutinib, or the second generation BTK inhibitor, zanubrutinib. Acala is not approved. Or you give ibrutinib plus rituximab, which is, we will come back to this later, in certain circumstances, perhaps also an idea. When you are medically non-fit, the tendency is always away from chemotherapy, and you give right away, as your first treatment already, BTK inhibitors. Perhaps we first move forward a little bit. So, as I said, rituximab chemotherapy is still a backbone of treatment. We just had recently, last year, the international consensus meeting organized by Steve Treon, so really international, US and European, and it was a clear statement for first line, also consent with the US colleagues, that this is true, what is written here. Rituximab chemotherapy is still a backbone of treatment. And we have, of course, we would have many options, but what is highlighted here in red is what is actually given. These are two regimens. One is called CDR, and which is actually, we call it DRC. It's just the sequence of the lettering. I think it's the US, they call it sometimes CDR. And it's rituximab bendamustine. Yeah, and you see here what you can achieve. I don't know whether I point, no, it's not working, but when you go through the columns, so the time to progression is important for you. And you see DRC is very effective, time to progression between, let's say, 3 years, 5 years. But you see also that rituximab bendamustine is more efficient with over 60 months time to progression, so 5-6 years. So you would say, okay, I would take R-Benda, but you never get anything without a price. It's more efficient, but it's also more toxic. Yeah, so this is why it's good to have both treatment regimens available. And Paul, perhaps you tell us a little bit about your experience, because you got one of these regimens, correct?
I was diagnosed with WM in the fall of 2014, and I was very fortunate to have a diagnosis. Even though I lived in Canada, it took place in Boston at Dana-Farber, and they recommended CDR. I immediately began that program in Canada, and tolerated it extremely well. I had a very busy lifestyle. I lived where I worked, and I was on that program for 18 weeks, and I didn't miss a day of work. I had to go have some naps, but I felt so blessed. Almost immediately, my hemoglobin started to recover. And so for me, CDR was extraordinarily successful, and I was very, very hopeful that I would get lots of months. At the end, I know I'm jumping ahead, they recommended maintenance, and I was so pleased with them. I went along and I did 2 years of maintenance. So by 2017, I had done my program and my maintenance, and my hemoglobin was still climbing back. So I couldn't have been less disrupted or happier with the treatment.
Yeah, and I think it's very, what Paul says. So again, it underlines that DRC or rituximab benda, so the concept of our chemo is still very valid, for sure. So we are talking about first line. So there was this study, just to show you a little bit what we are doing in the European consortium. Was a large study where we actually took up this idea of DRC. It's called IWMF study because our European consortium and is named like this. And you see what we did is we had Waldenstrom patients in need of treatment naive, and they were randomized, so distributed by chance into DRC, exactly what Paul got without maintenance actually, or bortezomib DRC, with the idea to improve the efficacy of DRC by adding bortezomib, because bortezomib is a drug which has a long history also in Waldenstrom, and it's still today a very powerful drug in patients with no neuropathy, because it can also cause neuropathy. So these are the takeaways from this study. So we had a very good efficacy of DRC. We confirmed this, and the time to response and how deep the response was, this was better in the bortezomib DRC arm. So when you have a patient, when you want to give DRC, he has a high tumor burden, he needs a rapid response, you can accelerate it by adding bortezomib. So the progression-free survival there was no difference. Yeah, it's important to know, but we just preparing a final analysis of the study with a much longer follow-up. So where we will see whether there was also a difference in the time to progression in favor of bortezomib, but we still do not have the data. So in conclusion, DRC was very well tolerated, and I think Paul just mentioned this also in his case. The hematotoxicity is very low, much lower than with Arbenda, and you can achieve quite good disease control in the majority of patients. And when you add bortezomib, you get faster responses, deeper responses, but it's not a must to give bortezomib. Yeah? We don't have any hints that you live longer when you add bortezomib. So the major question, Paul mentioned it, is also from our colleagues, is when you now have seen our chemo, should you add rituximab maintenance? And so I think it's quite a decision, because of course it makes a difference when you stop treatment after half a year, or you add normally 2 years, Paul. I don't know how long you got it.
2 years.
Yeah, you add 2 years more treatment. So it's a major decision. And rituximab normally is well tolerated, but it's also not water. So, so this was a study which was performed by my German colleague Matthias Rummel, and he analyzed whether rituximab maintenance after rituximab bendamustine, not after DRC, what Paul got, whether rituximab maintenance adds anything with regard to the time of progression. And as you see, there is no difference. So he could not confirm that rituximab maintenance in this study setting adds anything. So this is why we in Europe are more cautious in recommending rituximab maintenance in routine. But here again, it's a slight difference in the US, because I know that Steve Trion likes rituximab maintenance. And when you go into subpopulations in this study, this was not significant statistically. Patients who were at higher age who had a high tumor burden, they benefited from rituximab maintenance. So you see, sometimes it's a little bit difficult, but in general, we are not giving rituximab maintenance anymore. And don't forget, we had the COVID pandemic, and we learned a lot. And rituximab maintenance, of course, also increases the risk for infections.
When I had it, it was, the decision was made in 2015. I don't think that decision would have been recommended to me today. Lots been learned in the last 9 years.
Yeah, but it's never black and white. So you see, even when you go into the study, there are subgroups that had a benefit. And so I think you have to decide on a patient individual basis. Yeah, but you see, we want to inform you perfectly at this meeting. There are also cons. Yeah, so we have to see, when a patient has tremendous difficulties with recurrent infections, it would be an argument against rituximab maintenance nowadays. So it might differ. Yes, questions?
Just the question on the first slide. How many rounds of bendamustine suspecting that have?
Yes. So, I go back. So in this study, it's a very good question. This study, which is not our standard, patients got 6 cycles of fully dosed bendamustine, which is the doses in follicular lymphoma. And we do not recommend this. And it's a very good question, because when you look at the study, only the fittest actually received rituximab maintenance. So Matthias Rummel lost 1/3 of all patients on the way from first cycle rituximab benda to last cycle, and then they, were distributed to maintenance versus observation. So 1/3 of patients never made it to this point. Yeah, it was a selection again. Yeah, also limiting a little bit the data, selection of the fittest and most responsive patients in this study. What we recommend is to give 4 cycles of 90, but also 70 mg per square meter benda. Yeah, so because our benda is quite toxic. Yeah, we know this. So it's well tolerated, but it depletes your T cells, and T cells are immune effector cells, which are important for you. So rituximab chemo is important, but of course BTK inhibitors, you have heard about it, and this was the pivotal trial published by Steve Treon, which actually led to the approval of ibrutinib worldwide. Yeah, not worldwide is a big word, but in the majority of countries worldwide. And so it was a study which analyzed patients in relapse or being refractory to first treatment. It gave ibrutinib as a continuous treatment. And at that time, I cited the company, the problem is solved, but at that time it was the most powerful single agent we had in Waldenstrom, with a major response rate of around 90%, overall response rate of 90%, and major response rate means partial response or better, so 50% at least improvement. So this was fantastic, yeah. So and it's still the basis for us to, have ibrutinib as one of our standard treatments in Waldenstrom. So the challenges we see with ibrutinib is based on biology, and this comes back to the first words we said here in this session. So MYD88, CXCR4, as you know, can be mutated, so altered, or not. CXCR4 the same. And now you have 2 variables. They can be non-mutated or mutated. And you can form groups. You can divide your patients into groups according to the mutation of these 2 genes. So 2 variables, we had all mathematics in school, gives 4 groups. 1 is missing. Yeah, so this is biology. So because there are more or less no patients who are only CXCR4 mutated. So we have patients being only MYD88 mutated, patients who are double mutated, and patients who are non-mutated in both genes. And everybody of you would fall into one of the groups. And what Steve saw was that when he now splits up the patients into the 3 different groups, and when you look at the major response rate, you see that the patients with MYD88 alone are highly sensitive towards ibrutinib. The double mutated are intermediate-like responsive, and the MYD88 wild-type patients, which are a very small group of patients, none of them achieved a partial remission or better. So you see how biology translates into clinical, into the clinical world. So it's clinically important. So what we recommend, I think I don't have a slide with me, is that you should try to get your mutational status, because it has implications when you think about treatments later on. We would not recommend to give ibrutinib single agent in MYD88 wild-type patients. Very simple. And in the CXCR4 mutated patients, you would also think about alternatives to ibrutinib. No? This is also shown here on the right side. You see now the progression-free survival curves. And again, what you see with ibrutinib single agent, the MYD88 only mutated, they're doing best. The double mutated, they do intermediate, and the wild type, the time to progression is very short. So I don't have slides with me, but perhaps, Paul, we discuss a little bit what happened to you, because ibrutinib has another challenge. And this is a toxicity, it has side effects. And we will come back to this a little bit later, but perhaps in your own words, what happened to you?
In 2011, I'd had atrial fibrillation, and I'd had an ablation done, and that problem had been solved for me. So in 2020, my hemoglobin continued to go down, started to go down, and I was put on ibrutinib. Unfortunately, when I went on ibrutinib, my hemoglobin started to climb immediately, and I felt better, but I had my atrial fib come back. And as the 9 months that I was on ibrutinib, it got worse and worse, and my lifestyle was being debilitated by the atrial fib. Very fortunately, at that time, Canada had just approved zanubrutinib, and I was one of the very early Canadians who were approved to be on zanubrutinib for WM, and immediately my hemoglobin continued to improve. I was on ibrutinib one day, zanubrutinib the next day, didn't interrupt, and my atrial fib disappeared. So I was very blessed and fortunate that transition took place. That was the only problem that I had with ibrutinib was the atrial fib.
Yeah, so ibrutinib has, of course, side effects, and as it is a continuous, non-fixed duration treatment, you can imagine such a drug must be very well tolerated. Yeah, the chemotherapy has the advantage, let's say, that it can afford more side effects because you stop after half a year. But when you are, let's say, thought to take ibrutinib for a long, long time, these side effects are important and can really compromise the quality of a drug. So, there can be arthritis, rash, diarrhea, cardiac toxicity, hypertension. So this is all known, and we have to monitor the patients carefully to avoid these side effects. And when they appear, it can be a reason to stop the drug, as in the case of Paul. So we stay a little bit with ibrutinib still before we go to zanubrutinib, because one idea to overcome the problems you have seen with these CXCR4 mutated or MYD88 wild-type patients is to combine ibrutinib with rituximab. And so we have done a large trial on behalf of the European Consortium. It was a company-sponsored trial for labeling, for approval, but it was really done on behalf of the ECWM. So we randomized patients into ibrutinib rituximab versus placebo rituximab. And so the take-home message here was that also in CXCR4 mutated and also in MYD88 wild-type patients, ibrutinib now works when you add rituximab. Yeah, so what we have seen before with ibrutinib as a single agent treatment is different when you add rituximab. But of course, it's a more complex treatment. You have to add a second drug, yeah, and it's less convenient as just taking, let's say, ibrutinib as a single agent. Yeah, this is shown here. You see, again, these PFS curves, so the time to progression, and you also see the different genotypes. And in contrast to what I showed you before, these PFS curves are more or less the same, independent of the genotype. So this was a major discovery we had in this trial. So what we do is we recommend not to give ibrutinib single agent in CXCR4 mutated, but when you want to give ibrutinib, add rituximab, and the same for wild-type MYD88 patients. But we have a different option, and this is what Paul just told us, and this is the second generation BTKIs. And this was a very important study where, again, it was company-sponsored, but we were all involved, the US colleagues and we from the European Consortium, where now patients with Waldenstrom in need of treatment were randomized between ibrutinib, single agent, versus zanubrutinib, single agent, with the idea to see whether zanubrutinib is better than ibrutinib. And so this is the take-home message here. So zanubrutinib is more effective than ibrutinib. It's a quantitative difference. It's not huge, black or white, but it's more effective, let's say. It did not translate, we have to say, in a longer treatment to time to progression. But what we see is that the responses are deeper. The most important observation in this study, and this is exactly what Paul said, is that it has less toxicities. It has less cardiac toxicities. It's better tolerated, very simple. And this is why zanubrutinib has become so important. So when you have a patient not tolerating ibrutinib anymore, but responds still well. So you would only stop ibrutinib because of the side effects, but it's still a very effective drug. What a pity. You don't want to stop the treatment concept. You can now switch to zanubrutinib, so you stay on the same treatment mode of action, but you try to get rid of the side effects. And Paul's example is like out of an educational book, but it's real. Yeah, so this is really an excellent example how switching can preserve for you this very important mode of action of BTK inhibition. Yeah, and what we have also seen is that zanubrutinib is more effective in CXCR4 mutated patients and also in MYD88 non-mutated patients. So when you want to do single agent BTK inhibitor treatment, zanubrutinib is for us in Europe first choice, very simple. So when we start a patient newly on a BTK inhibitor, we don't take ibrutinib, and we also don't take ibrutinib rituximab because it's more complicated to give compared to zanubrutinib. This is again shown. You see here in this is the time to adverse events, so the time to the development of atrial fibrillation or hypertension. And in blue, there's ibrutinib, and in red is zanubrutinib. This is the difference when you look at many, many patients. So it's better tolerated. So, yeah, I think, Paul, you mentioned this already. Of course, don't see it that zanubrutinib has no side effects. It's the same class of drug. So there are patients having the same side effects as with ibrutinib. Arthritis, rash, diarrhea. Paul, you don't have any side effects. So you are.
I do, but
not.
They feel so minor compared to my mother and everything else that we live with them, and I think we all do with WM. There are things that I have a little peripheral neuropathy, diarrhea is a continuous problem, but to me it's so minor. I'm happy to be here.
And how you are here. Yeah, okay. Now, just that don't have the feeling Zanu is like causing not anything. It's the same class of, but they are nice data retrospectively where they analyzed how many of the patients, had reduced symptoms or even symptoms disappeared or symptoms getting worse after switching from ibrutinib to zanubrutinib. So there are now several data sets, and they all show convincingly that in the majority of patients, indeed, you have improvement of symptoms. Yeah, some even have no symptoms. So the majority has an improvement of symptoms. And importantly, these data also show the efficacy is not lost because, of course, this would be a catastrophe. You have a little bit less symptoms, but your disease is not controlled anymore. So also these data clearly show the disease control is perfect and Paul, you just mentioned your story, and it's like this. Okay, relapse. Well, 15 minutes. So relapse.
Yeah, we're in trouble.
No, I will go through. Relapse, very simple. When you relapse, normally you give BTK inhibitors, and we discussed them at length. So BTK inhibitors are the major tool you have in the relapse setting, because also, at least in our country, many patients still got rituximab chemotherapy. So it's the first time they see a BTK inhibitor. Yeah, actually, I think these are just already the summary slides. So how the current treatment looks like, first line, timing, do not harm. Actually, it's a wording of, was it not Waldenstrom himself? I think only start treatment if you need to do. Choose between our chemo or BTK inhibitors. Of course, clinical trials are important because it's a rare disease. And in relapse, again, timing, do not harm. Also in relapse, watch and wait, absolutely important. The relapse, when we see it in a CAT scan or whatever, is not a reason to start immediately treatment. We do exactly the same again. We watch and wait when you are not compromised in your quality of life. And then choose between rituximab chemo or BTK, but as I said, BTK inhibitors are really dominating, and again, clinical trials. So where are we going? Most recent update of the IWMF research roadmap priorities. Paul, it's your mission and vision, and we are thankful.
Well, we're really proud to be part of the WM community for the whole world. And our vision is very clear. It's a world without WM, and we've got to all be in the same vision in that regard. We know at the IWMF that we can do certain things to help out, that we can be partners for local organizations, and we're good with information. I think we're very good with research. We are so blessed that the clinicians and the researchers have joined us. It feels like we're a team together. And the second part of the IWMF's team is the partners we have around the world, WMUK. We recently established a group in Estonia, and we all suffer from the same challenges and dilemmas. And if we can continue to provide the information, provide the research, and partner with local areas so that you can have the information, and then you can have the idiosyncrasies you need for your area and your health system to combine with our knowledge and the research, together we can beat WM. You can't do it on your own as a small group. We can't do it on our own from a distance, but coming together, we absolutely believe we can. So the IWMF has started research in 2000. We've invested over $30 million. We are planning in the next 5 years to invest a further $31 million. We in 2024, we gave out research projects for $3.1 million and one of the great things about our research is it's done all over the world. So we don't care who's doing it. We have various people apply. We have an RFP that goes out across the world, and more than half of our research projects last year were won by researchers outside of North America. So from our point of view, that's great. We want the best researchers in the world doing the best research, so we make the most progress. Yeah, I want you to explain this one because I know you told me to, but
exactly. So yeah, just to echo, it's an amazing project, and we are sitting now in Europe, we as Europeans really benefit dramatically from the IWMF. And you see, these are, we defined together. So there's like a steering or advisory committee, let's say, and again, this is composed of US, North American, and European colleagues. So we defined roadmap priorities. So you see WM cell biology, and you also as patients, you see how important it is to understand biology. Look at these mighty 88 CXCR4 story, T-cell based therapeutics. Yeah, so important because we see new developments. We mentioned the bispecific antibodies, which use your own T cells to fight cancer. We know that Waldenstrom cells are not living on its own. They are living in their own niche, yeah, in their living room. The living room consists of many other cells. So these other cells are feeding the Waldenstrom cells. So it's very important to understand how this living room works. How Waldenstrom cells talk with this microenvironment, because you could again think about treatments which are not targeting the Waldenstrom cells, but the niche, because we know without the niche, the Waldenstrom cells are dead in minutes. They don't survive. Genomic research, this is what we talked about, MIDI88. Proteomics means proteins. Yeah, so genes are converted into proteins. Proteins, you can be modified by sugar entities. So one gene can cause thousands of different proteins. So it's an even higher layer of complexity. But what counts to the end is a protein, not a gene. And this is why the IWMF also is performing research on proteomics. So, Paul, you want to say this, or because what is nice is they have different research categories, yeah?
Yep. We have different categories for different types of researchers. We know we have a cadre of senior veteran clinicians, but we need younger people in it too, who are just starting their research projects. So we have the strategic roadmaps, which we've had their $1.5 million, their $400,000 grants that give out over 2 years. We have an extended roadmap research grant that's $1.5 million that will take at least 3 years. We have Kyle research grants, which are for younger researchers. We have seed money for people who just have an idea and they just want a little bit of money to just see if that will spur something in WM. We have a companion. Do you know anything about the companion research?
Yes.
We've had one companion research proposal, and Christian won it last year. So we're so proud to have it. And we're establishing the WMNet, which is in North America, in the US. But we're emulating what has been so well done in Europe, which is clinical research done with many different sites. What the problem with clinical trials with WM is, if you have the site in London, you only have people who are close to London who can contribute. But if you can have 15 different sites all over Europe open, you only need 2 or 3 patients at every site to have enough patients. And that's one of the biggest troubles we've had with clinical trials, is getting the enrollment for WM because of the rare disease. So we're emulating what Christian and his colleagues have done in Europe, in North America, to see if we can get more clinical trials taking place.
Yeah, so because I think I will skip all this. It just shows you, I think Paul mentioned it beautifully, that it's really an initiative which goes beyond North America. So it's really also like for us Europeans so important. So now we have 5 minutes. I will just show you very few. I think immunotherapy. I just want to mention this one concept. Yeah, what I just said, and these bispecifics and this concept, this is really coming. And Waldenstrom is at the very beginning, but in other lymphomas, it's already approved and used and reimbursed. Yeah, and it's so nice, this concept, because it's your own immune system which fights cancer. So you are the one who wins against cancer. And this is something totally different conceptually as was what we had before. Because before, you were like passive. You got your chemotherapy, or even with ibrutinib, you take something from outside and you hope that this from outside will help you. But with this concept, we as physicians, we are just helping you a little bit. We are triggering the initial reaction, but you on your own, you will make it. And this is, I think it's really great, and it puts you as a patient into the center of treatment. So, and these are the bispecific antibodies, as I said. So this first trial, Josephine sitting in the back I think is running already, including first patients. So this is the idea of bispecific antibodies. So just that you heard. So what is the idea? So you have T cells. T cells are fighting cancer. T cells are fighting lymphoma. So they are so important, but for certain reasons, they don't manage it to be effective enough to fight your Waldenstrom or another lymphoma. So the idea is now to help your own T cells to become so fit that the lymphoma has no chance. So how do you do this? You infuse or also sub-Q. You get an antibody which binds to your lymphoma cell and to your own T cell. So it just brings lymphoma cells and T cells to a close proximity, to a neighborhood. So they are close together. So, and then your own T cells get so fit, so aggressive, that they kill your lymphoma cell. So this sounds like fairy tale, but it's amazing. We know it from aggressive lymphoma and follicular lymphoma. It's amazing. So I have really patients who were out-treated, no treatment anymore with aggressive lymphoma, they are cured. So it's a dramatic effect these antibodies have, and we hope really that we see, and I think there's no reason not to believe this, we see the same in Waldenstrom. So so this is the idea and the concept that you are in the center of treatment, because these are your cells, not the physician's cells, they are not coming from outside. So I skip this. And I think these are the last slides. But we can discuss new developments later on. I think like a red line in this session was the motto that we have really to work together as patients with physicians, physicians with patients. Networking is so important. Paul said it. We cannot do things alone. No chance. We can only do things together. And this is why we, from the physician's side, founded, as I said, the European Consortium for Waldenstrom's Macroglobulinemia with many, many colleagues throughout Europe. And so Lisa is also sitting in the back. So she is organizing this European Consortium. And there will be a poster in lunchtime so that you can also inform yourself about the European Consortium. And what we are planning to do with you is the next annual meeting a little bit together, because we thought it would be so great to have our annual meeting we have as physicians. So there's an annual meeting from the European Consortium, from us physicians, with your WM patient forum. And Hannah is here, and she is so important for organizing this meeting for you. And Lisa from the, as I said, physicians side. And this is what we are planning. Yeah, so it's a save the date. And I think it will be a wonderful meeting at a wonderful place. So we plan it at the 21st of May next year. So at a beautiful time, spring is there, in Chantilly, France. It's a beautiful place because it's also close to the airport. It's just 20 minutes taxi drive from the airport, so it's very well accessible. We found a wonderful hotel. It's like a retreat. It's beautiful.
Do you have a picture?
Yeah, and you know, this is of course a minor reason also to come. It's the castle of Chantilly. It's really unique. It's spectacular. It's one of the great painting collections worldwide, so we will have a chance to go in and to get a guided tour. So, yeah, save the date. We would be very happy to see you all there. It's the first time that we do it like this, but I think it's really a win-win situation for all of us. So with this, Paul, we are 40 seconds over time, but I hope that the organizers give us a little bit time for questions. So I hope that they're not that strict. So even in
What? No. You cutting us off?
or let's say 2-3 questions. I think that's possible. I think we should not be stricter than in academic physicians meetings.
Are there any questions?
I'm just wondering if post-Brexit, so you keep referring to the Europe, is zanubrutinib, will that be available in the UK, or is that available in the UK as treatment?
Sure. Yeah, so of course we see the UK still as part of Europe. So and actually our UK colleagues, Shirley sitting here, are really one of the most committed members of the European Consortium. Shirley, I think yes it is, and I know that, for instance, the bispecifics, CAR T cells, were very fast approved in the UK now. But perhaps, Shirley, you just say a word.
So zanubrutinib is approved for the Waldenstrom's already, but not at frontline in the UK. But it's approved by NICE for second onwards line. So it's already there, which is great. And as Christian says, other developments are ongoing with, for example, CAR T, bispecifics. I think Waldenstrom's is sort of waiting in the wings a little bit to get a look in, but it's on its way. So there's a lot going on, and I have to assure you that we very much strive to be with the European part of the European group on this front. Certainly at a personal level, with all the colleagues, works extremely well.
Thank you.
So you had a question?
You mentioned that one of your slides. Is there any clinical trial of CAR T?
Yeah, so the question was on CAR T cells. Is there any clinical trial? Perhaps Shirley and Josephine, they have to correct me. So not that I know. So at the moment in Europe, there was a trial, but actually it was closed for Waldenstrom, a commercial trial. And Shirley, Josephine, I don't think that in Europe we have an ongoing CAR T cell trial for Waldenstrom, but please correct me.
I'm aware only of trials where transformed Waldenstrom patient can be included for CAR T, so that means when it's transformed to a high-grade lymphoma. And for a lot of CAR T trials, Waldenstrom is excluded because very often toxicities are different in Waldenstrom from other indications, so we need a dedicated CAR T trial for Waldenstrom. I think there's one in the States, but not here at the moment. But we're happy very soon have the bispecific trial, which is a similar concept, working with T cells.
There was another trial?
Just have last question here. Yes, similar to some of those, I'm just wondering, insurance and payment aside, and what is being done to sort of equalize the different types of treatments available in the US versus the UK and Europe? And at the moment, is one of those regions better to get treatment than another?
So the question, Paul, was whether what is done to compensate for these imbalances in the availability of drugs between European countries and US and Europe. And when you would have Waldenstrom, it's better to go to the US or to Europe? No, I just simplify it a little bit. No, I think in Europe we have all important drugs available. Yeah, of course there might be country-specific differences. So we have zanubrutinib, and when we have zanubrutinib, we are not urgently depending on acalabrutinib because they are very similar. Yeah, and the CAR-Ts is the same in the US. So there's actually, it's one small trial, but I know that the company is not pursuing the CAR-Ts commercially for Waldenstrom, so they have the same problems. So in that sense, and we are working really close together, so the treatment algorithms are very similar between the US and Europe. This is also reflected by the fact that we have these international consensus meetings. We have now a large, perhaps some of you are going, a larger meeting in Prague, International Waldenstrom meeting. And here again, we will write down consensus statements, so to harmonize treatments in Europe and in the US. So on both sides of the Atlantic, you are perfectly cared for.